our opening on the board, and as is part of our process, she's attending to see exactly what we do. It's not totally new to her, but I'm going to ask her a little bit later to tell us a little bit about what she does in the community. So anyway, so are we ready to start then?
Yeah, Greg gave us a thumbs up.
Okay, great. Yeah, just to remind everybody that this meeting is recorded and being live streamed on the county YouTube channel. So usually we don't do introductions with Zoom because we're all labeled here. So that takes care of that. But we do have two guests, as I mentioned. Beth McGee is here, and Liddy Barger is joining us to be part of our presentation tonight. So welcome. Are there any additions or deletions to the agenda? Anyone wants to? Larry?
Is Liddy talking about the plans for St. John's Community Service?
Well, I believe we invited Liddy, and maybe Frank can clarify, to just give us an update on homelessness in the area, and you know, kind of in the vein of, we had talked about discussing housing issues at the beginning of the year. So this is one opportunity for us to get some more information on that general issue of homelessness.
So I guess what I'm wanting to add to the agenda is a discussion of development of a project at St. John's Community Service. So if we could, and all I'm asking when we get to it is if we could invite them to come and talk either to the mental health subcommittee or to the community services board.
Okay.
Because it sounds like a major project and we should know about it.
Okay, sounds good. All right, thank you. So moving on to approving the minutes, can I have a motion to approve them? Tom? Yeah, second. Sheila? Any discussion about them? Any corrections? Okay, so all in favor of approving them? Okay, I think we've passed them. Thank you. Great. Okay, and any privilege of the floor? Any comments? All right. And any announcements anyone wants to make? Larry, did you have your?
Well, since I missed the privilege of the floor, I'll just take a minute, well, a second to say I had my first vaccine at the mall, and the process was really, really efficient. So that's credit to the health department and to Hugo Medical Center. So it was very well done.
Excellent. Yeah, we were talking just before the meeting. There's been a lot of good experiences, efficient experiences folks mentioned. It's great.
I had both shots there, and it went well. No problem.
Wonderful.
I don't want to say we have to do it again, but if it happens again, I hope they do the same thing all over and it worked fine.
That's great.
We're never doing this again.
Well, I'm not saying we should.
We'll be lining up for our boosters in 6 months.
Bite your tongue, Elise. Now, Shauna has her electronic hand up, Mary.
I'm sorry. Go ahead, Shauna.
Thank you, Mary. I just wanted to update everyone on the Reimagine Public Safety conversation that both the Ithaca Common Council and the Tompkins County Legislature voted on this past week. It did pass both bodies, and The legislature, as well as the Common Council, did add a few different points. As far as, I think that one of the most contentious things was probably coming out of the city of Ithaca, to essentially dismantle the Ithaca Police. And that has actually been taken off of the table, and there's been some conversations between the Ithaca Police and the Common Council, and there is going to be a revamping of sorts. As far as the legislature is concerned, one of the big contentious items was where the SWAT vehicle would be landing and where it would go. I ended up having a conversation with Lieutenant Young and decided that the SWAT vehicle would better be suited for the city of Ithaca. They host 80% of the people that are on the SWAT team. And the main idea behind keeping it with the Ithaca Police Department was that we had heard feedback that whenever that RV pulled up in front of someone's house, that it was very, very triggering for many people. And so the idea is that we are going to completely rebrand that vehicle. It will receive a paint job, as well as we have been promised that there will no longer be weapons that will be housed on the SWAT vehicle. Also, there will be outreach in the communities, and it will essentially be used for a central command whenever there's an emergency in our community. And as I mentioned, both the city council as well as the legislature did submit our executive 203 orders to the governor's office, and they have been accepted. So I just wanted to update everyone as to that.
Thank you. Shauna, what is the next step with that planning?
This was probably the easiest part. There is so much left to it as far as figuring out what the Ithaca Police is going to look like moving forward. Figuring out how one important part that we added to our sheriff's department was adding more community policing, which in rural areas can be difficult sometimes because it's not a matter of like riding your bike on the commons. It's a little bit harder to provide that community policing idea. And so, essentially from the county, it's going to involve, we're going to be part of the CAHOOTS program, which I think many of you are familiar with. And we're going to have a more responsive mental health response instead of coming in there blazing with military-like vehicles. And I'm not saying that our sheriff's department does that anyway. I believe Derek Osborne, at least over the past 2 or 3 years, has taken a very hands-off approach as far as working with people that struggle with mental health issues. But I think we're going to continue that conversation and take on a different model.
Okay. Any questions for Shauna? Okay, well, thanks so much for the update. Good. And just to invite you all, I do my best to try to see if people's hands are up, but I take feedback anytime about that if I've missed something. So if anyone notices something, just let me know. Thank you. All right, so I think we can go on to our presentation. I appreciate Liddy joining us tonight, and we're interested in hearing about your work and what would be important for us to know in our roles here.
Sure. Thank you all for having me. I'm happy to be here. I don't have like a PowerPoint for you, but I've come to just sort of talk. And so if you find yourself with questions as I'm talking, I'm pretty chat savvy. You can feel free to put them in the chat, or you can wait till the end. I don't know what your culture of this meeting is. But I was asked to come to talk about sort of like the current state of homelessness in our community, and some ways that the pandemic has affected that population. So just because I don't know everyone in this room, I'm going to introduce myself. My name is Liddy Barger. I'm the coordinator of housing initiatives. I work for Human Services Coalition. And I sort of wear a couple hats there, but one of them is to coordinate what's called the continuum of care. Continuum of cares exist in every community in the country. Ours is unique because we're a single county continuum of care. So we're really hyper focused on Tompkins County and the city of Ithaca, which I really appreciate in my role, that I get to sort of really just zero in on our community, the community where I live. We are responsible for planning and coordination in the homeless response system. We're also the entity that's responsible for data management for the community. So we operate what's called the Homeless Management Information System, which is an open data sharing portal that's used by basically all the providers in the homeless response system, from street outreach all the way to permanent supportive housing providers. And then we also manage what's called coordinated entry, which is a way of prioritizing people experiencing homelessness for the appropriate and available housing that we have to offer. As you guys know, Tompkins County, pretty skimpy options for supportive housing or really permanent housing in general, but we do the best with what we have. We also include transitional housing in that process and some other rapid rehousing style programs for people. And then we also do what's called the point in time count, which is this yearly thing that HUD has everybody do in the last 10 days of January. We all go out and attempt to enumerate the number of people experiencing homelessness, both in shelters and unsheltered in a given catchment. This year, our point in time count was a little bit different than other years. We don't need to get into that, although I can tell you that there were 33 people sleeping outside on the night of January 28th, and about 115 in shelter. As far as like what homelessness looks like in our community, we have a higher than would be expected number of people experiencing homelessness in our region. The shelter averages in its very sort of lowest numbers about 60 people a night, but really tends to serve more like 90 to 120 and up to 180 people. So obviously they're not all staying in the shelter, and especially this is one of the sort of changes that pandemic has brought. So the shelter itself is very small. It's 20 beds in their emergency shelter function. And then anybody else who isn't in the on-site shelter is housed in motels. They have several contracts with several motels in the community. One of the very first sort of pandemic related changes was that they reduced their density by 50% on site in the shelter, about a year ago now. Feels like we've been doing this a long time, and started putting all persons into motels, which is a smart and good public health measure, but did change the nature of the level of services that people had access to on sort of like a 24/7 basis. Certainly the community and the homeless response system noticed that there was sort of an uptick in some mental health issues happening in the motel spaces, and pretty like rampant substance use issues in those motel spaces, because they just don't have their motels. They don't have staff on site to be managing, doing any kind of case management or even really like companionship or comfort keeping stuff with the people who are staying in there. So the encampment is always of great interest to people. I will say that our community had a strong collaboration form early on in the pandemic. We call ourselves the Enhanced Street Outreach Team, and started to very quickly, in fact, I just had to look up the date the other day. So I noticed that the first date of the meeting that we sent out was March 19th of 2020. So pretty quickly started meeting with all of the people who do street outreach or other sort of immediate needs services, and trying to figure out how we can pivot to serve people on site in the encampment so that they were able to shelter in place, sort of just like the rest of us were told to do, right? So meal delivery started a year ago. There was sanitation services brought in, so there's some portable toilets in that space now. There have been a whole bunch of hand washing stations that have been, they're like camp hand washing stations. So they've been like made and distributed a few times at this point in the effort because they're tempting. Just this increase of collaboration. But the real sort of like jewel in that collaboration was that for the first time ever, we were able to do some medical street outreach for people who are in that space. So Reach Medical joined as a partner and has been doing on-site telehealth in the encampment space about 6 hours a week for the last year. And they've also been able to do mobile COVID testing with vulnerable populations. And now I think they're starting to take on some of the vaccination effort, specifically with people experiencing homelessness and other vulnerable populations. It has been a very successful effort. It's been, I think, sort of life-saving. We did have some COVID cases that happened in the encampment, but they were really quickly sort of contained, just like you would want them to be, even when people didn't come into quarantine style shelter. Like there were people who chose to quarantine in the encampment, and so we still managed to maintain that infection, which is kind of like a miracle. I remember it was like a Friday afternoon when I heard like the first positive case had happened, and I was like, oh, we're doomed. But it really did not turn out that way. And it has a lot to do with the collaborative efforts of all of these agencies coming together. Prior to COVID, you know, there's a lot of silver linings now that we can sort of reflect back on some of this stuff. And one of them is that things that we didn't think were possible became possible. And one of those things to me was this medical street outreach thing. So people were getting care for emergent things like, you know, trench foot, but also sort of access to some amount of mental health treatment, medicated assisted treatment for substance use disorder, right where they are. And so the medical street outreach guy would go around and basically be like, you want to talk to me today? And people would say no, and then they'd see him the next day and they'd be like, all right, yeah, I'm ready, let's talk. And it launched some people on sort of health journeys that I would not have predicted necessarily for those folks. And that has to do with trust and all of those things. So I think that's a notable thing to mention. At the sort of peak of the summer, we had about like 55 to 60 people in the encampment spaces. Right now, I think it's closer to 40. We've had some great successes with getting people into some permanent housing solutions, and some people who just have decided to come at least into emergency shelter. So they're not living outdoors anymore, but they are still in the shelter system. You know, another of the silver linings, if that's a thing, about COVID is that there has been this sort of influx of resources around homeless response and housing that our community has never actually had come into our area before. So HUD, as part of the CARES Act, released something that's called ESGCV, which I won't test you on the acronym, but and it has brought, you know, it will, by the end of the 2 allotments that we have, bring just under $1 million into our community, dedicated to people experiencing homelessness in the form of rapid rehousing vouchers, homeless prevention assistance, legal services, and some other things. We've never had that funding come into our community. So that's another of the sort of silver linings. That also comes with a high level of collaboration. HUD requires that the COC be part of any planning conversations around like homeless response dollars. But we were already doing it. So we were at an advantage that like our Tompkins County DSS was already collaborating with Human Services Coalition and has already been at sort of all of these tables. So we weren't, we didn't have to like create new relationships and then learn how to collaborate together. We'd already sort of been doing that work. And that ESG funding is another intervention that's working, right? So people get referred to the rapid rehousing programs through coordinated entry, which I touched on briefly at the beginning, and have been accepted very quickly into the program. Where we get a little hitch is in finding available housing. So we are finding ourselves to be in a phenomenon where there are, at this point, like almost 24 people who are still homeless with what amounts to basically a year of rent in their pockets, and rent at fair market rate. So they could be housed if we had safe, appropriate, available housing for them and landlords willing to rent to them. So that's sort of our current, one of our current challenges. It's a hard population to sell to landlords, right? And we are trying a number of approaches with landlords, including HSC has a landlord engagement program and a mitigation fund, and is working really hard to be like, we'll help you if you have a hard time with your tenants. But it's been a tough sell, I think, to find that housing. And we really are committed to not having people going into substandard housing whenever possible. So what we have as far as available housing in our community is either basically substandard or very expensive. And we don't have a lot of that, what I would call naturally occurring affordable housing, or housing that's affordable to people who are in the sort of 0 to 30% area median income range. And that's a challenge that we're working on. We're still working on it. If people want to talk to me about ideas, I'd love to hear them. Another sort of phenomenon that we have seen in our population of people experiencing homelessness is a real disconnect from some of their service providers. So there was some folks who had been part of the health homes program who had some intensive case management, and that got phased out, or they had technology issues, so they could have had access to their case manager or their therapist, but their phones were hard to keep charged or on, or they would get lost. And that has been a challenge because as much as the people who do the street outreach and who are doing the direct service work as hard as they can to keep people connected to technology and phones and minutes and Wi-Fi, it's pretty hard. It's pretty hard, especially in the encampment space. And the relationships get lost, so after, you miss one appointment, okay, you miss 2 appointments, and then you're sort of, eventually you get closed out from whatever your provider was, and you have to sort of kind of start back at the beginning. I know that mental health keeps people open. Tompkins County Mental Health keeps people open for a period of time, a longer period of time, depending on circumstances. And so do the CARS and ADC, but it still feels like the beginning again. I think when people go to reengage, that's something I've heard is like, ugh, I don't want to have to do the whole like intake process again, or go to open access or whatever it is. They just want to be able to like have their person, whoever they trusted, and have access to that person and be able to schedule with that person. And a lot of that will, I think, when things do start opening up a little bit more, we're going to be able to find some solutions for it. But during the sort of dead of shutdown, people certainly lost those relationships with their providers and are working to reestablish them. REACH does do sort of like a brief mental health intervention, but they're not long-term, therapists. There is a psychiatrist on staff, but she would like to be able to refer people to the therapists at other places. It's not designed to be a long-term relationship, what they have there. I'm trying to think what else. I don't know. I've sort of rambled on a bit here. I'm trying to just focus on, this is a mental health and substance use subcommittee. Is that who you all are?
All
Okay.
3 disability areas. Yeah. Well,
Okay.
maybe we could take some questions if,
Yeah, I'd love to answer questions. What do you know about the disconnect for health home clients? Is the new provider aware what we expect?
So let me explain what I mean. The county used to run the health home program, and we didn't re-up for the contract, and another provider was found. So Frank, when you give your report, can you address my question?
Sure.
Because if people are losing their connection with the health homes, these are the people that we are most in need to make sure that they maintain their connections to the services. And if they are losing them, maybe we need to intervene.
Yeah.
So I actually had a question about the extent to which the people that you're working with, the people who are experiencing homelessness or are at risk for homelessness, how much of it is a disability, both either mental health disability or physical disability, part of the puzzle?
So I just ran some quick numbers for 2020 right before we came into the meeting for some data for you. All the data that I have is self-report. So it's coming from, it's clients reporting their own beliefs about where they are on those things. I think that's important to say. About 64% of our population of people in the shelter and that are street homeless report having both a mental health and a substance use disorder. And it's a slightly lower number for people who are in shelter. It's more like 50%. And then once you get to the permanent supportive housing levels, it's an even lower number, which is interesting because you can sort of almost see how stabilizing improves your relationship with mental health and substance use stuff. But it's a key contributor for people experiencing homelessness, and it doesn't get better while you're homeless, right? Like it's very hard to take care of those issues when you are also trying to figure out like how to eat and be, the rain is coming in your tent. I mean, it's hard to do those long-term things. So so about 64% of people and almost everybody, I was sort of like drilling down on some of the data. So almost everybody who says that they have a substance use disorder also say that they have a mental health problem, but not the other way around. So, and the people who say a mental health issue only, it's like 20-something% of people. And that's a separate group than the 60%. So basically 80-something% of everybody in our data system has one or the other or both mental health, substance use. Physical disabilities are a little bit lower, but certainly overrepresented in the homeless response system. I actually think we have a little bit of a flaw in the way that we ask the question in our intake that is making our numbers look a little bit lower than they are, because it basically says, have you ever received Social Security disability? There's like a few ways that they ask it, but it never just says like, do you feel like you have a physical disability that has affected your housing? So we do need to work on that specific question. Oh, we ask about chronic health conditions also, and that's pretty high across the board, regardless of comorbidities. It's not a super physically healthy population, right? So for a variety of reasons. And that's why, with Reach as a partner, it's been so valuable just to meet people where they are right now, and not have this sort of predetermined idea about what physical or mental wellness looks like, but just say like, where are you today? And how can we, help you out with what you need? And then maybe tomorrow you'll be somewhere else with your needs, and we'll get you there tomorrow. Instead of sort of being like, I want you to go to detox and rehab and halfway house. It's just sort of like that. It's very person-centered and meeting people where they are with mental health and substance use and physical stuff. I've seen Reach do some amazing things with people with some chronic health conditions, and that it just has to do with that trust factor.
Any other questions for Liddy?
Liddy, you're aware of the second wind kind
Oh,
of
sure.
stuff? Yeah, okay.
Mhm.
A thought that occurred to me, it has occurred to me for several years, having worked in the jungle with this population. And I've always thought that a constructive thing would be to put she sheds out there, a whole bunch of them, as just a basic shelter, rather than have them living in, whatever they're living in, to be safe. Whereas the providers of service could go out and, visit them in a safe place, for mental health purposes, or in my field, substance abuse, but at least they'd be in a safe place, or safer place, I think. But I don't know how this would ever come about, but
Yeah.
this thought's been in the back of my head for a long time, so I'm going to ask it.
You're not alone in that thought. A couple responses to that. You have to first, there are plenty of structures in the encampment. So I know we all picture it being like tents, but there are really more permanent structures, including somebody who has like solar panels and a composting toilet.
Really?
But yes, it's a pretty enterprising bunch. But you have to be very careful about sanctioning encampments, right? It's a process. So I think a lot of us, and I am included in this, feel this urge to be like, let's just put roofs over their head and figure it out later. But there's a lot of unintended consequences to that, right? We don't want, so from the COC, the Continuum of Care, we believe that every person has a right to housing, and that housing should be safe, decent, and like fully livable, right? Bathrooms, kitchens, all of those things. And so sort of throwing up a sanctioned encampment, which is sort of what you're talking about, is kind of saying like, this is acceptable to us, that it's acceptable, that we think that people should live this way. And I believe in person-centered choices. If people want to live that way, it's different. But it kind of there's a few unintended consequences. The other thing is like, that's actually not a suitable. So something like a tiny house project or a tiny house village is a considered best practices in some places. The actual encampment is a swamp. So you don't want to build out there. It's not really a great place to try to put in permanent structures. And it's also not sanctioning the encampment isn't really what the residents of that space desire. So there's a reason that some folks are living in sort of a wild gray area and popping up a bunch of structures and bringing in a bunch of case management and turning it into essentially a shelter isn't going to, my guess is there would just still be an encampment somewhere else. Because what of that? It also belongs to the city. So right now the city, obviously is aware of the encampment, but practices what we call like tacit acceptance. But putting an infrastructure is just sort of a whole nother level. It's a commitment that I don't think our community is at this time going to undertake.
I know the city years ago wanted to get rid of the jungle, period. Just
Sure.
eliminate the jungle. Well,
Yeah,
that wasn't going to work either. So
yeah, there is, people are doing it's a complicated situation. And, I find myself, I can get very sort of carried away in the way I think about it because, I care a lot about people making choices for themselves, but then I also wonder a lot about consent and what is consent if you are suffering with substance use disorder and mental health issues. You can say, yes, this is what I'm choosing. I'm choosing to live out here. I want to live out here. But I'm not totally sure. It gets very hard to tease apart, right? What is consent and how does that relate to, how does that interplay with these issues that we're talking about of mental health, substance abuse? It's very easy. I can get very,
well, I think one of the things is that if you made it more habitable, a lot of the people who are there don't want that. They want to go out. They'll move someplace else and
they will
into the same kind of environment that they're already in. So,
right. I mean, so we at this point are able to, for years, I've been working in and around this field and said, I just want to be able to go into the encampment and say, rapid rehousing vouchers for anyone who wants them, right? Because then you can kind of suss out at least who believes that they're giving consent to live there and who doesn't, right? We could say that we got housing for everyone, anybody who wants to go, and we've never had an opportunity until now. Now we really can go into that space and say, if you want a housing voucher, you've got it. And it's been interesting to see, who's accepting that offer and who isn't. It tends to be more women who are choosing to come indoors now that there's more housing opportunities for people. It's a younger group of people that are coming inside. Yep. But there's definitely some old timers out in that space that aren't coming in.
They're not coming in, guaranteed.
We should probably wrap up here. Paul, maybe one last question. Paula, you had a...
Yeah, I had a question about housing and landlords and the substandard housing that you don't want to put people in. Are landlords renting that? Are they able to get people to pay what you can pay to live in that substandard housing?
Our substandard housing is fully occupied at almost all times.
Okay, so there's no incentive to having them fix it up to the level of where you would consider housing.
Not in our community, but that doesn't mean that there aren't opportunities to do work in the substandard housing issue that we have. So that's, I guess, my short answer to that. People who have a housing voucher, a temporary housing assistance through Tompkins County DSS pays at $400, the maximum amount of money you're going to get for an individual is what they call it a total needs grant, and it's $400 a month. That there is no housing that isn't substandard that can make their books work for $400 a month. So that it's worth knowing that's the economics of that. These rapid rehousing vouchers pay at fair market rent. So the newer vouchers and some of the other programs can pay at a higher rate, but if you just have sort of straight up DSS assistance, housing assistance, your entire rent and all of your total needs need to be paid with $400 a month. So substandard housing it is for now.
Liddy, thank you so much for
Thank you.
coming and enlightening us on this topic. I'm struck by some of the data that you mentioned about the incidence of mental illness and substance use issues. That's really helpful for us to understand that.
Thanks.
Yeah.
I put my email in the chat. I am very easy to reach. I exist here in this community and I'm happy to talk, or if people have other questions or whatever, I'm happy to be available to folks.
Well, that's great. Good. Well, thank you very much for coming. We appreciate
Thanks.
it. Great.
Have a good meeting. I'm gonna
Yeah.
see what my daughter's doing.
Thanks. Take care. All right. Just moving on with our agenda. My report, I was going to introduce Beth. I'm not sure if she's there or she might have had, oh, there she is. Good. Yeah, I was just going to give Beth an opportunity to tell us a little bit about herself and what she does in our community. And as you know, we have an opening currently, and we're talking to different folks about their interest in the opening. And one of our steps in our process is to have candidates attend a meeting and introduce themselves. So I'll see if Beth can share a little bit.
Thanks, Mary. And thanks for allowing me a minute here. I did attend several meetings in 2018 when I was considering applying for the committee, and things became challenging, as they often do with families trying to navigate these issues. So that didn't end up being a good time. I'm the executive director at NAMI Finger Lakes. That's the local chapter of the National Alliance on Mental Illness. We're located in Ithaca and right now everywhere virtually. So we have lots of programming, education programs, support groups, and we've also been holding the Family Forum online, which is a monthly program where we've talked about mental health crisis response since the fall. NAMI is the National Alliance on Mental Illness. For anyone who does not know that, it is the largest grassroots mental health organization dedicated to building better lives for the millions of Americans affected by mental illness. Before becoming their executive director, I also trained to become a support group facilitator for them and teach their signature programs for families, including families of veterans. I'm also certified through NAMI to lead advocacy training workshops to teach community members how to advocate for their needs with stakeholders and policymakers. I serve on the NAMI New York State Government Affairs Committee, and we work together to develop a legislative agenda each year and help facilitate meetings with our local representatives for family members and peers who are experiencing mental health conditions to advocate for the things that we need. This year, we met with our own Assemblywoman Anna Kellis and with a representative of Senator Tom O'Mara to ask them to support the HALT legislation, funding for the upcoming 988 implementation for suicide prevention. Also, to reinstate the 20% holdbacks for mental health organizations and services, and many other initiatives that we're encouraging the community to reach out to their legislators for. I came to be concerned about mental health in our area because we have a loved one whose life has been interrupted time and time again by a serious persistent mental illness. This person that we love, as well as all people who are impacted by mental illness, deserve the care and services that are going to let them live in their best recovery. I often feel like I'm fighting for this population and my loved one as if they're a burden rather than a valuable member of the community that deserves to be able to live well. And I would like to have an opportunity to share resources with this board and serve the community in this way if it's needed. So we can provide a really positive level of care that we can all celebrate and that exceeds our expectations. So I'm happy to answer any questions. I can put my email in the chat if people wanted to reach out to me further.
Great. Thank you, Beth.
Mhm.
Great. Larry?
I should also point out that Beth has been coming regularly and participating really well with the mental health subcommittee. So I think she's demonstrated a commitment to serving on these, on the committees and on the board. So I'm very pleased she's applying for membership. I think the family voice is important as we talk about what's needed in the community.
Thanks, Larry.
Thank you. Good. Well, I'm glad you can join us, Beth, and thank you for coming. So
Sure, I appreciate your work. Thank you.
good. Yeah, feel free to continue to be here for this meeting. That's
Sure.
Thank you. All right, so we have a deputy commissioner. This is exciting here. So we are going to have an update from Harmony, and I think Frank will probably join her in adding whatever he needs to also.
Thank you. So I've been in the position for almost a month now, so I have a few things I can update you on. I just wanted to say something about Beth's comment about care that exceeds our expectations. I think that's such a beautiful way to put what we all strive for and want to achieve in our community. So that was a great thing to hear and keep in mind. Thank you for saying that, Beth. I just attended one of the family forums, and that was really a lovely experience to meet the members of that group at NAMI and to hear such a well put together presentation. So some of the things I've been up to, I've met with all of the staff. Of course, that's virtually in team meetings and things like that. So over the next few months, I will be contacting everyone one-on-one, either by phone or Zoom or something, because it's so hard you can't just pop in anyone's office right now. So it's an interesting time to start. But I really want to get to know everybody a little bit individually to start. And of course, meeting regularly with the leadership team. And to some of the things that Larry said, I do know, Larry, that we have a rapid re-engagement program where people, if they lose contact with their therapist and their case is closed out, they can do a rapid re-engagement process. So they don't have to redo the entire intake process. It speeds that piece up for people. And when people request that they have their therapist they saw before, every attempt is made to give them that therapist. Sometimes people say, I want a different therapist, right? So it's up to what the person wants, but they have started that protocol, and it seems to be working well. Of course, the needs are great, and there is a wait list to get people back in. And obviously with COVID, it's challenging to try and use technology that doesn't always work very well. So hopefully in the future, people will be able to reconnect in easier ways. They did open access up again for a couple of days a week. So we're tipping our toes back into the water and hopefully being able to do more of that. And I also wanted to let you know that with the people who are receiving REACH counseling services, which are brief in their focus, and oftentimes they're trauma therapy that people are receiving, because they might come in to see a substance use provider, and in the course of that beginning process, they start talking about some of the trauma they've experienced. They get some counseling services, but they really need something more long-term. So there's a pretty good warm handoff between the REACH program and our clinic. I know that the clinic director here meets regularly with REACH to help support that work. So there are some efforts being made to really support people when they are in those transition places, because transitions are challenging. That's when you can really lose people, right? They might quit services when they really want them and need them if that process doesn't go well. So there are attempts to make that go well. So beyond meeting with everyone, I did get to attend everyone's subcommittee this last month. So that was really good. I'm looking forward to attending them more. I'm hoping to bring some information to the people, the committee chairs, around needs assessment information that I can find for the state, that's both state and local, as we start thinking about our priority plan for 2021, because we don't know what that plan might look like, but starting to think about what are those needs, how have they changed, reviewing what we were looking at in 2020 would be a good place to start and see what changes there might be. And I kind of feel like none of us really know, because we don't really know how COVID's impacted a lot of things for people yet. So that would probably require a lot of discussion, even though we may not really see the impact of all of this that we've been going through right away. I've been meeting with community service providers. I started with the substance use service providers and have met with their leadership. I meet with CARS this week and met with REACH and Tompkins County Alcohol and Drug Council already. And the next group of providers I'm reaching out to are the housing providers. So I'm sure you can see the pattern there, like where are our most vulnerable people? They're often getting mental health services and substance use services, or they're that need to be well coordinated, and housing is a pretty big issue. So that's really where I'm focused. I'm also looking at the health home care management piece because of those transitions that happened during a challenging year. How are those services working? Are people getting them? So that's next on my list. I'm meeting with someone this week who's going to walk me through step by step what the process looks like, who our current providers are, what their sense of how that's going is, and then reaching out directly to those providers, because I really want to get a sense of it. But it's not just who the health home care managers are, it's what services people can actually get access to through the health home that matters. And do we have enough of those services in our community? So those are some of the things I really want to prioritize and look at. Meeting with SPOA and SPO, met with the ACT team. So I'm trying to get a sense of, like, big picture, do we have enough services and supports in our community? So if you have somebody in the health home person who's going to line you up with services, but those services just exist on paper, that's a problem that we may need to work towards remedying. There are lots of issues facing providers in our community. It's very, very hard to fill positions. And anybody that's in this group that's working at an agency like that, probably Jan, you have these experiences. It's hard to hire people and find qualified people right now. So that's a pretty big barrier, along with housing, is really finding qualified people to do the work. And there are no simple solutions to those problems, but I think those are some of the areas to focus on. I'm also learning about the alternatives to incarceration courts, or problem-solving courts. Focused a lot so far on the Ithaca Health and Mental Health and Recovery Court, but we'll be learning more about the other courts. So I got to say, I said to Frank, how many courts are there in this county that I have to learn? So I'm figuring out who all the people are that are working in those systems, and it's really just amazing to be a part of a community that really takes mental health, behavioral health so seriously, that they have created these systems to really address a lot of people's problems. There's gaps, there's definitely places to improve, right? But it's really a community that strives to help support people to be successful. And it's really wonderful to meet people who are so dedicated and working hard every day to find solutions and make things better in the midst of all of the crisis that we have been experiencing. And so those are some of the highlights, I would say. But any questions you have for me or ideas of things you think, because it's vast, right? The job is vast. So if you want to narrow it down for me a little bit, that would be great too. Like, go look at this. But I got to tell you, I'm excited. I wrote a note after listening to Liddy's comments about housing. I have a friend who started a program called, I had to look it up, Tiny Homes for Good. I don't know if any of you are familiar with it. It's out in Syracuse. But it's a homelessness program. They start out in Syracuse where they use spaces where they're just like empty lots. And they've built these really nice small homes on them for people that are in recovery. That give them a safe and dignified place to live that don't cost a lot of money. So there are some really creative options out there. You want to take a look at that program. I know the person who started it. I went to school with him. He looked like he was 12 when we went to school together, when I got my public administration degree about 5 years ago. And just a phenomenal person. He was actually, while he was in college, was living with 3 homeless people, previously homeless people. And he started a bicycle program while we were in school to help people get bicycles for transportation. So I know he might be an interesting person for you to check out and see if that's a potential solution down the road. I just throw that out there because I got really excited listening to some of the stuff Liddy was saying. But any questions for me, thoughts of what I should do? Larry?
So maybe you and Frank can answer this together. Who is the current contractor for health homes in our community? And are they aware that the disconnects that Libby was referencing are happening? And what is their plan for reconnecting to people? Because, I mean, health homes were developed in part because people who had experienced long-term hospitalization needed assistance. So these are the people for whom the entire mental health system in the community was developed in the first place. And if we're not connecting to those people, then we need to do something else.
Yeah, so actually there's now 4 entities that are subcontracted to provide health home services in the county. I'm gonna get the names messed up except for Stapp and Lakeview, because we know them. The other 2 are newer entities, at least to our community. As far as the transition, when it occurred, there was a warm handoff with every one of our clients.
Sure.
The health home program is not mandatory. And so there was quite a few folks that didn't want to transition to another agency.
Okay.
And that's part of, I think, where when people are saying disconnect, I think that is a piece of that puzzle. I would also point out, Larry, you gave the health homes a very good description on what they were. Quite frankly, in my opinion, it was the state's effort to reduce costs and shift the program out of.
Oh, I agree with that completely.
Yeah,
I'm just saying.
Yeah, no, and I appreciate what you said as well, and that really was the goal. But I think what we're finding, and what a lot of communities have already found out that don't have counties that were subsidizing their health home program, is that it is different, and it is a paper process. Really identifying those high-risk folks that are more likely to use emergency room services and other high-cost interventions, and trying to provide them as much support as they can. But what we found is that in order to be sustainable on the financial model that was established, your caseloads have to be 50 plus, particularly for the non-legacy spaces. And if you have 50 plus clients, you're not providing intensive case management. You just can't. It's not possible. So I think what we have to envision, of course, 2020 just threw a wrench into everything too, is we have to see how this continues to evolve. And as we're identifying those individuals that need more help, figuring out what the appropriate way is to build that support system for them. So I don't want anyone to think that we're just leaving these folks out there. And I also don't want anyone to think that the health homes are failing because of lack of trying. I think it's just a combination of a transition time, the true reality of what health homes is actually able to provide when it's not subsidized by the county, and then a transition period in 2020 when everything was kind of up in the air, and trying to make sure that those folks are connected with services. So where we haven't lost those folks, and Harmony's on her to-do list is getting familiar with those other agencies, and figuring out, where the gaps might exist now. And then we can talk about, what should we be doing to try to fill those gaps.
Good.
Right, so Larry, what he's saying there is the health home care manager really is just organizing the services the person's supposed to have. And I went to a meeting last week where the state recognized that some of those more intensive services that people need, the health home care manager doesn't actually provide. They get the person set up with those services. So this meeting I went to last week, they were saying they realized that people weren't getting those services as quickly as they should because they had so much paperwork that they were requiring the health homes to do to get people access to those services. So now they're changing that model at the state level to reduce that paperwork. So when I reach out to the health home care providers, I can find out and it looks like there's funding to help with that transition to some of those services. So it's really not only the health home care provider who helps organize all the services, it's the people who are actually going to go out into the field and provide them. And do we have enough of those? And it looks like the state is putting some money towards some of those services, and they're reimagining that design a little bit so that the health home care manager doesn't have to spend hours putting this packet together. And then you can't get all the information you need, so it doesn't get finished in a timely way, and all these sort of barriers they've had. So I think they're learning some of these systems issues have to be sort of worked out. So I'm hopeful that in the future that process is going to get better. So that's some of the stuff I'll be talking to them about, like how do we support them to make sure people get access to those services, because it is a totally different model than what people used to have in these, where people used to have a care manager that could provide really intensive services. Now it's like a menu of services, but you have to get access to all of them, and someone else might be providing those services. So it's got some growing pains.
So lastly, I just wanted to say, the more you get to know Liddy Barger, the more she's a huge resource on homeless services. I mean, I like her a lot. Anyway.
I put her email down. This was perfect.
Good. So just checking in on the agenda here, we will not need to have an executive session today. So we have about a half hour left and 2 more topics to cover, but I just wanted to check in with Frank. Was there anything additional to add to Harmony's report?
No, the one COVID thing I would want to add is that between this meeting and your last, we did make over 200 appointments available to clients of Family and Children's, the mental health department, and our OASIS providers. So they got a special link. We called people. We used our text system to alert them to try to make sure that folks that are receiving mental health and substance use services could get an appointment to get vaccinated. So we feel like we got to the point where we had no one left to call. And we made some pretty good inroads. The state Elmira Psychiatric Center was also doing clinics throughout the region, and they did one at their ACT office a couple of weeks ago there in Ithaca, and we really focused on our housing providers for those folks, because most of the housing providers are downtown and it would be walkable if they chose. So there were multiple opportunities, and I just wanted you guys to know that we made that concerted effort to get those folks access to the vaccine.
That's great. Good. All right. Thank you. So moving on to the next topic, many of us had a chance to attend the Zoom meeting where the staff presented the the strategic plan for the integrated department. And we just wanted to give you all an opportunity to ask any questions that came up for you, or any clarification that was needed. I think it was the first time it wasn't in a draft form. Is that true, Frank?
Yeah, it was kind of the culmination of all the work that the staff team and the advisory group put together. What I would share is it's the foundation, right? I did hear from some folks about, the lack of detail in there. And quite frankly, we heard that from staff too, because everyone wants to know, what are we doing next, right? What is it we're very specifically going to work on? And this really was about creating the framework. And now the hard work comes with trying to begin to implement the plan. And from a next step perspective, the senior leadership team is meeting next week to look at the list of priorities and begin to put timeframes to them. What are we doing in year 1, 2, and 3? And then figuring out what are the first cross-functional teams that we're going to create. And so we're going to use a charter model where each team will have a charter. So the senior leadership team will kind of put the skeleton together for the charter, and then it'll be handed off to those teams to kind of carry it forward from there. So that's kind of how the process of building the detail around the work to be done is going to occur. We are investigating continuing our relationship with the Batiste Group to help facilitate the cross-functional teams, build some leadership skills within those teams and within the senior leadership team along these lines. So that way we're building a process that can be replicated over and over again. They'll help us the first couple of times, teach us how to do it, and then we'll move on to where we don't need their support anymore. I'm also looking to try to find resource to bring on, I'm calling it a project manager. We'll come up with a better title as we're doing it, but someone that can be the workhorse as far as scheduling meetings, make sure agendas are created, make sure that the things are moving forward, checking in with the leads on the teams, doing the general legwork to make sure that it continues to move forward. It'd be a short-term position. It's nothing permanent, but we know all the rest of us are busy with our regular jobs. And if there isn't someone just monitoring that progress and doing those small tasks that really matter in order to move it forward, we might lose some momentum. So we're evaluating both of those things, and we'll likely be looking to continue the support with Batiste and possibly bring on someone to help kind of manage the project moving forward. But we're working on it. It's good stuff. Staff are excited and are interested in beginning to do the work, and so that's exciting. And I think it will align with what's going on in the community, including the public safety reform conversations that are occurring. So I want to thank everyone that participated so far, and certainly you guys will be a big part of the process as we move forward as well.
Any questions for Frank? Frank, how do you imagine updating this group? Will it be part of your agenda each month, or?
Yeah, I think we're still figuring that out. I mean, I will certainly give you a verbal update as a minimum about where we're working, but I think we're still trying to imagine what a more formal reporting of progress will look like. We're setting up bi-weekly senior leadership team meetings that will be specifically to talk to the cross-functional teams about any barriers that they're facing, to check on progress and continue to move that forward. And then from there, we'll need a summary of some sort that would be more, appropriate for you guys at your level. So we're still working on the details of exactly what it'll look like, but we absolutely expect for both you and the Board of Health that we'll be giving, regular reports about progress and what we're working on.
Great. Okay.
Elise has her hand up, Mary.
Sorry, I'm trying to raise my hand and I keep clapping
I saw
instead.
you clapping. I'm like, wow.
So I was just going to ask, just in terms of keeping us updated in the future, it sounds like, the last report out sounded like everyone did a lot of great work around visioning and norms of collaboration, but it wasn't a whole lot of next steps information. So I think to me, I'm looking forward to hearing more about the practicality of it, the logistics, the operations process of, sort of reforming the two departments.
Sure. Yeah, absolutely. And we'll be kind of hashing some of that out in the coming weeks. We can certainly provide you with the charters as they're developed for the cross-functional work groups. The one thing we're trying to be mindful of is staff are still pretty overwhelmed with everything else that's going on. So we don't want to lose momentum. We want to keep moving forward, and where there's energy, we want to open that door for folks to apply it. But we also don't want to overwhelm them any more than they already are. So we're trying to be realistic about what we're going to be able to achieve in the next 6 months or so. So yeah, no, we'll absolutely share that progress as we begin to develop the details of moving forward.
Okay. Anything else on that? Good. All right. The last topic was to give you all an update on some changes that are in process with Challenge. A small group of us, Jan, Elise, Sheila, and Larry, and I met with the outgoing executive director of Challenge back in February to learn more about what their plans were regarding an affiliation with a group called Mosaic. It had, my understanding, and please help me, anyone else who was part of that meeting. My understanding is that due to financial issues, partially related to COVID, but more of a long-term nature, that Challenge had pursued an affiliation with another organization that would provide them some opportunity to share administrative staffing. So we had learned about this kind of after a lot had already gone forward. And at this point, we're planning a second meeting with the new folks who are part of this affiliation. But we wanted to make sure you all knew that this was going on and to give us some thoughts about questions we should be pursuing in this follow-up meeting that we'll be having probably sometime in a month or so. Does anyone else want to flesh that out anymore?
Yeah, I think, just in terms of what this board is primarily concerned with is related to vocational services for people with a primary mental health diagnosis. So Mosaic is an ARC, and ARCs, most ARCs exclusively serve people with developmental disabilities, although they can be very big and they can have lots of different types of programs. But we want to make sure that all of the people that were able to receive vocational supports through Challenge prior to the partnership with Mosaic will still be able to receive those types of supports and services. And I think, another concern that I think I have that I want to try to get to the bottom of a little bit more is the rate at which they are engaging people in programs that are designed to result in competitive integrated employment, as opposed to things like enclave settings like their dish room programs. And so that is sort of something that's it's come to light through the process of this partnership. Because, when Joe met with us, one of the reasons he gave for the need for the partnership is that, basically there had been such massive job losses because the dish rooms had closed. Whereas, I've been hearing from a lot of other similar agencies around the state that it's been sort of 50-50 because, when you employ a lot of people with disabilities in competitive integrated employment, a lot of them tend to be essential workers. So it was sort of a mixed bag of job loss. And that made me wonder if they had been over relying on enclave models and that rather than competitive integrated employment. So I think there's just a few things that, that we'd like some clarity around, just so that we can get a sense of the scope and type of services that are and will be available to people in terms of, vocational supports.
Jan?
Yeah, just to continue off what Elise said, I think ARCs are also really into the enclave model. The Seneca ARC, that is one of the two that's forming Mosaic, did a lot of defense contracts where they made wool hats and so on. Not that that's important exactly what they do, but just that it wasn't competitive integrated employment for the most part. And the Seneca ARC also decided, it was around 2008, that they would no longer serve people with mental health issues, that they wanted to get back to their roots, as they put it, of serving people with only developmental disabilities. And of course, my hope is that maybe Mosaic formed to be a more complete and inclusive group that didn't put certain populations out. That's, I guess, yet to be seen. So it just makes me a little nervous.
Sheila?
Yeah, I think Jan and Elise have kind of talked about, I think, our biggest concern. What Joe was talking about, at least from what I was able to gather from the conversation, one of the drivers was for this alliance was, or affiliation, was the focus on manufacturing. And so I guess I have a lot of questions around that. Is it integrative? What does it look like? As Jan said, is this an enclave model? Because we really want to, be moving away from that. So I think there was a lot of questions around that for me, and what does it look like going forward? Also, my understanding, and Jan and Elise and others, the board composition, from what I could understand, the two boards would still exist, but there would be members from each board on the other board. Was that your understanding?
Yes, that they would sort of sit on each other's boards, but maintain separate boards. Although,
Right.
It would be hard to see that arrangement going on too long, but
Yeah.
from a practical standpoint.
Right, I agree. I'd also like to know a little bit more about the financial piece, as well as the leadership. We know that the executive director of Mosaic will be taking over the leadership of this new organization, or this, this alliance. But what else, who else from Challenge is going to be part of that leadership? There has been some movement out, as we all know. So just a lot of questions around that. What's that going to look like?
And
And it
certainly,
Go ahead. Sorry, Jan.
I was just going to comment that Seneca County is so different from Tompkins County. And when we worked in both counties, it was really apparent. So I also worry a little bit about the whole culture of bringing this organization in, who's has a different idea of how best to serve people with disabilities.
Larry?
And sorry.
I was just gonna say, when the ARC of the United States and other ARCs were really supporting the elimination of sub-minimum wage, a few of, or at least one of the ARCs in this area opposed the elimination of sub-minimum wage. and the national arc had to tell them to get in line. So just to support what Jan is saying, the culture about what people with disabilities are capable of is slightly different in other counties in this part of the world.
And I don't want to get too much into the policy weeds, but suffice it to say that all federal rules and regulations and statutes and evolving legislation, that may be pending in the near future moves away from this type of employment model. And so one of the things that I worry about when I hear manufacturing is that it's code for older sheltered models of employment, although sometimes people or agencies are successful at changing them just enough to be able to say that they're not sheltered workshops anymore. But they're definitely not, the types of jobs that would be competed for in the community. But they do, I think that Joe did mention, and when I referenced something about Source America contracts, which is, it is a way of contracting for work for people with disabilities that historically was segregated. And there's been a lot of controversy around that. And so it's really complicated. It's not something we can get into in this meeting, but just know that as we dig into this, there are a lot of interconnecting issues and rules and regulations and pending regulations from CMS as well that would impact potentially the settings that people are served in.
Okay, thank you. So we have, Jan, did you?
I guess I just wanted to say one last thing, and that's if in fact their plan is that they won't serve people with mental health disabilities that need supported employment or some other group, or their model evolves to discontinue that in a few years, that we should be prepared to think about, how to fill that need.
Mm-hmm. Yes. So as you can see, there's a lot of questions we have, and what our plan is to meet with this new administration and ask these questions and get back to this group with our impressions of things. From what you've heard, are there any other questions you'd like us to explore during a future meeting with them?
So,
Jackie?
Just a question, I guess, in terms of the financial support that we provide, the contract that we have with them, is that for support of specific populations, or is it general? Is that a leveraging tool we have? I'm just wondering what.
Yes. And there are some county dollars, I believe, that Challenge gets as well, which we directly dictate what those are used for. So the way that I understand it, the way that it was described was that Challenge isn't going away, right? So the entity of Challenge will still exist, and there will be this new board and governance structure in this alliance with Mosaic. So from that perspective, we're still contracting with Challenge for those same things. I'll ask I'll ask Jeremy to give us a rundown of the funding that we provide to Challenge, so that way the folks that meet with the Mosaic's leadership will have that at their fingertips as we go. But yeah, and even beyond the financial, this board and the LGU has a responsibility of providing mental health, substance use disorder, and developmental disability services. And I think this alliance, merger, whatever it might be, concept, we need to get used to it, because I think it's only going to happen more and more, particularly with small nonprofits, as it becomes harder to remain sustainable. So as much as we can learn about how we want to be involved in these conversations, knowing that we might not find out until the decision is over, right? Because these are often private corporate conversations that are being had. But knowing, what our process is, how we want people to report to us, how we want to interact with a new entity when it's formed, right? I know there's some angst about this, but we've got to work with Mosaic, and we want to make sure that our first interactions with them are as positive as they can be, while making sure they understand our expectations. I wasn't saying any names, Larry.
No, I mean, and I think that that's important, because it isn't really Challenge or Mosaic or whatever. It's service provision.
Yep.
That we have not only a legal obligation, but certainly feel a moral and ethical obligation about. And if they aren't doing that, do those dollars belong somewhere else?
Yep.
Yeah, they definitely get OMH dollars. It used to be for specific programs, and some was general, and then it became kind of all one lump sum.
Yeah, and there's been a reduction in funding, right? They're not paying for some things anymore. And that's part of where the financial issues came in. And one thing that I was a little uncomfortable with from Joe was that they made it sound like it was a surprise that this funding was going away. But what the state's been telling us is they've been talking with Challenge for years about this funding going away, and that there was plenty of time to prepare and understand that the model was shifting. So this is tough, right? It's tough. An agency we all know, love, and care about is having troubles, and they've had them for a while. And I think they're doing the best they can, from their perspective for what's best for their organization. I think what Kaki was alluding to, our responsibility is to make sure that whatever's happening is in the best interest of the people that we're responsible for serving.
Good. So we will keep you informed about this. And if you have other thoughts, let any of us know. And we'll get back to you about what happens in our next meeting. Good. We've really come to the end of the agenda. We had the nominating committee had thought that we might need some time for an executive session, but we are continuing to talk to applicants and pursuing references, and have a group of really wonderful applicants for all of our openings. So we're making progress there. And the nominating committee is also codifying our process a little bit. We have a meeting later this month to articulate in a written document what our process is, and hopefully be able to be as clear as possible for any applicants that come our way. So good work is happening there. Great.
Mary Elise and Larry have their hands up.
Oh, thank you. Larry, do you want to go?
So about the project that St. John's Community Service is pursuing, do you want them to come to the mental health subcommittee or to the community services board to talk about it? I haven't looked at it very much, but one of the things that I can tell you is that they're looking at buying a hotel, or maybe more than one hotel, and housing people, I think, on emergency basis. And one of the issues is how many people per room are they meaning for the project to serve? So should that come to the mental health subcommittee or to the community services board?
So I texted with Rich Bennett after you asked that question, Larry. He's willing to have himself or someone come to the next community services board meeting and present on it. What Larry's referring to is we believe that St. John's applied for CDBG funds, community development block grant funds, to potentially make a purchase of a local hotel to expand homeless occupation. Rich was saying it's very, very preliminary. It's really kind of the first steps in this, but he's more than willing to come to the board. And so we'll try to get him or someone from St. John's lined up for your May meeting to talk about what they're proposing.
If they'd like to talk about it sooner, I'd be happy to have them at the mental health subcommittee. But if we want to wait, then that's fine with me too.
Sure.
Okay. Elise, did you have your hand up?
Yeah, just very quickly, I just wanted to, we can talk about it next month, but we do need one more member representative on the DD subcommittee. So we'll be looking for another member to join the DD subcommittee, please and thank you. So if everyone could think about that, that'd be great.
That's a board member, right? The
Mhm.
position?
Yeah.
Great, thank you. All right, so if there's nothing else, am I missing any hands here? Everything? Okay, good. So can I have a motion to adjourn the meeting? Sheila, and a second for Tom. All right. All in favor? All right, thanks, everybody. Appreciate
Thank
your time.
you.
Bye.
Bye.
Bye.